Hello, my name is Dr. Shannon Piget, equine radiologist and ultrasonographer.
And I'm Dr. Heidi Riesing, equine surgeon here at UC Davis. We're excited to be here to talk to you about ultrasound-guided intralesional tendon and ligament injections in the horse.
This method is best applied to core or focal intratendinous lesions, most commonly affecting the superficial and deep digital flexor tendons and the suspensory ligament. For clarity, we'll use the superficial digital flexor tendon as our primary example. Ultrasound guidance is essential for accurate and safe delivery of orthobiologics into tendon or ligament lesions. Blind techniques risk inaccurate placement and collateral tissue damage. Ultrasound-guided intralesional injections ensure that medications are precisely deposited into the lesion core. Orthobiologics include acellular, cellular, and gene therapies. In horses, the most common orthobiologics used to treat tendon injuries are platelet-rich plasma, autologous conditioned serum, and stem cell therapies. Evidence shows improved tendon fiber alignment, smaller lesion size, and a decreased re-injury rate when PRP or other cell-based therapies are delivered intralesionally.
Whenever you are performing an ultrasound-guided procedure, the patient should be lightly sedated, typically with a combination of an alpha-2 agonist and an opioid, such that it stands quietly without swaying. A twitch may be used if needed. Make sure to position the machine and yourself for comfort and safety before starting. The region of interest should have already been clipped and washed. Perform a complete ultrasound examination of the region in transverse, as shown, and longitudinal planes to document the size, echogenicity, and degree of fiber disruption of the lesion. The lesion should be located with ultrasound and marked on the skin outside of the region of the sterile prep. We like whiteout correction fluid as it shows up on horses of all coat colors. Next, the limb should be aseptically prepared. You will want to desensitize the limb with a local anesthetic like mepivacaine. Perineural anesthesia with a high 4-point nerve block will desensitize most locations, but the specific block performed will depend upon the lesion location. A subcutaneous bleb or superficial line block may also be used. However, this may result in gas artifact that could obscure needle visualization if performed too near the area of injury. For the injection, you can use either a linear or a microconvex transducer. The linear transducer generally provides better resolution, but can make needle positioning more challenging, especially for deeper structures. The mid-frequency microconvex offers greater flexibility when placing and guiding the needle. Sterile preparation of the transducer is also important to avoid contamination. Apply ultrasound gel to the probe. For extra precaution, sterile gel can be used. Pick up the sterile glove and open the cuff as wide as possible to insert the probe. Slide the probe smoothly into the glove, ensuring the glove fully covers the length of the probe. Pull the glove down to extend it completely over the base of the probe. With your other hand, fold the glove's fingers and thumb back towards the probe. Secure the glove at the base of the probe with tape to prevent slippage and maintain sterility. Clinicians should match the needle gauge to the injected viscosity and cell fragility to protect product integrity and improve delivery. Needle diameter of 25 gauge or smaller should be avoided for MSCs or BMAC. Injected volume is typically determined by the product type, but lesion size can also be taken into consideration. Excessive volumes can cause damage. Recommendation for needles, syringes, and volumes for commonly used orthobiologics are provided here. Products can be drawn up into multiple 3 ml syringes to facilitate multiple injections into larger lesions. We recommend positioning the needle in plane with the ultrasound beam, as this allows continuous visualization of the needle, ensuring the needle tip is correctly positioned within the lesion. In plane positioning can be performed either in longitudinal or transverse positions depending on axis. The most direct needle path that avoids puncture of adjacent structures should be chosen. Spray with alcohol and locate the lesion using the whiteout mark. When placing the needle and during the injection, continuously monitor the process under ultrasound. The syringe should be tightly secured to the needle to avoid inadvertent loss or leakage of the injectate. The ultrasonographer should then visualize the needle tip and confirm it is in place, signaling to the assistant that they can inject. Inject slowly, watching for visualization of the injected within the lesion, and it may contain gas echoes. If resistance is encountered or the injectate is visualized leaking from the lesion, reposition the needle slightly but never force the injection. After the injection, rescan the tendon or ligament to confirm distribution of the injectate. The injected volume should be documented on the stored ultrasound image, the imaging report, or both.
Finally, apply a bandage and begin a structured rehabilitation program with ultrasound rechecks scheduled at 6 to 8 weeks. Clinical research highlights the value of ultrasound-guided intralesional delivery of orthobiologics. While recommendations will continue to evolve as more data becomes available, a few studies highlighting the benefits of orthobiologic therapies are listed here.
Ultrasound guidance maximizes accuracy, safety, and efficacy of tendon and ligament injections.
We hope this video will help you with your future ultrasound-guided procedures.